Hello students, hope you're all doing good. In this video, we are going to discuss about the various types of ectopic pregnancy in detail and also the management for ectopic pregnancy. Okay. Now, as we have already seen, which is the most common site of ectopic pregnancy? Yes, it is the fallopian tubes. So, fallopian tubes are the most common site of ectopic pregnancy. And in the fallopian tubes, which is the most common site? Yes, it is the ampulla followed by isthmus followed by the infundibulum and lastly it is the interstitium. Okay. Now, why ampulla is the most common site of ectopic pregnancy? We have seen two reasons. One, there is a increased number of plicae in the ampulla and also it is the site of fertilization. Okay. And followed by fallopian tube, which is the most common site? Yes, it is the ovaries. Ovaries are the second most common site, right? So, in this picture, we will see what are the various sites of ectopic pregnancy. Yes, it is the fallopian tube, which are the commonest site. So, in the fallopian tube, it is the ampulla first, followed by the isthmus, followed by the infundibulum, okay, and then the interstitial, right? And then the ovarian ectopic is the second most common site of ectopic pregnancy. You can also have a cervical pregnancy in the cervix or an abdominal pregnancy which will be happening in the abdominal cavity or even a peritoneal pregnancy. Okay. Now, if you take a tubal ectopic, it can have two fates. Okay. It can go for rupture or it can go for abortion. So, tubal ectopic can go for tubal rupture or tubal abortion. Okay. So, first we will see about tubal rupture. Okay. Most of the times the tubal rupture can happen spontaneously. Okay. Or it can also happen during coitus as well as if a bimanual examination is done. Okay. And in tubal rupture, there will be increased amount of hemorrhage inside the abdominal cavity and sometimes it can end up as a life-threatening situation also. Okay. So, this is a picture for tubal rupture. Okay. So, an ectopic has formed here and it is going for rupture where you are able to see the blood that is coming down it is getting collected. Okay. So, either it can get collected in the pouch of ductlets or it can form a hemoperitoneum and sometimes it can also irritate the uterus. Okay. So, this is a laparoscopic picture, okay, where you are able to see ectopic pregnancy at 5 weeks of gestational age that has gone for a rupture and you are able to see the blood has come out and it has got for clotting. Okay. Next one, there can be tubal abortion also. How tubal abortion happens means mostly in the cases of a ectopic that has implanted in the infundibulum. What happens is the products of conception will be expelled into the abdominal cavity through the ostium. Okay. So, when an ectopic is present in the infundibulum, the products are extruded into the abdomen through the ostium. Clear? Now in this case, if you ask about the bleeding, it can be in either way. Okay, either it can be minimal or there can be severe bleeding that can be enough to collect in the cul-de-sac also. Okay, and remember, see, this is a picture of tubal abortion. Okay, so what is happening? It is coming out through the ostia out there in the infundibulum, and there is a minimal amount of bleeding coming, and when this extruded, what happens is sometimes it can get implanted anywhere in the abdominal cavity and it can turn out to a abdominal pregnancy also. Clear? Yes. So these are the two fates of a tubal ectopic. Clear? In this, I want to specifically talk about the interstitial pregnancy. Okay. So what is an interstitial tubal ectopic? It implants in the tubal segment that lies within the muscular wall, right? So, if a tubal ectopic is growing like this, okay, we have already seen in this area if a pregnancy is growing, what is going to happen? It gets supports from the myometrium also, and this pregnancy can be carried up even up to 16 weeks of gestational age, okay, and then it will not be going for any abortion, right? So, most of the times what happens is there will be a rupture. Okay, and this rupture can be catastrophic sometimes, and there can be increased amount of hemorrhage and bleeding, and sometimes even this kind of rupture can end up in mortality. Okay, so the mortality rate can be as high as 2.5%. Clear? Clear? So that is the importance of interstitial ectopic. And if we specifically see the ultrasound findings of interstitial ectopic, you can see a G-sac that is separated from the endometrium. Then this G-sac can be seen more than 1 centimeter away from the endometrial cavity. You will also be able to see a sign called as interstitial line sign, which is an echogenic line that is extending from the G-sac towards the uterine cavity. Okay. Extending from the G-sac to the uterine cavity. Okay. So, this is a picture of a right interstitial ectopic pregnancy. See, you have the uterus, okay, you have the uterus, and in the uterus, this is where the fallopian tubes are going to start. So, at this region, you are having an ectopic, and if you see, this is an interstitial line sign, okay, that you will be able to make out in an ultrasonogram. I have shown a schematic representation, okay. So, this is the interstitial line sign where it will be extending from the G-sac towards the endometrial cavity. Clear? And remember, you will be having normal tubes and ovaries in interstitial pregnancy. Clear? Okay. So, at this point, I want to make clear about what is interstitial pregnancy and what is angular pregnancy. Okay. So, we will see what is interstitial pregnancy and what is angular pregnancy. Okay. So, already we have seen interstitial pregnancy is a pregnancy which happens in the interstitial part of the fallopian tube, right? Yes. So, it happens in the interstitial part of the fallopian tube. Whereas angular pregnancy is a pregnancy that happens in the endometrial cavity itself. Okay, but remember, it will be happening just medial to the uterotubal junction. Okay, suppose if I draw a pic like this, see, if I draw a pic like this, okay, so you have an interstitial pregnancy here. Okay, so this is the tubes. Okay, let us consider this as the uterus. Okay, the endometrial cavity or the uterus is starting from this. So, a pregnancy which is happening in this interstitial part of the fallopian tube is an interstitial pregnancy. Whereas an angular pregnancy happens in the endometrial cavity alone, just medial to this uterotubal junction. Okay, and it is seen in the supralateral aspect of the endometrial cavity. Can you understand? Yes. So, this happens in the endometrial cavity, and we have seen two criteria. What is the criteria? It is seen medial to the uterotubal junction and it is seen in the supralateral aspect of the uterus. Okay. And then we have to see the relationship to the round ligament. Suppose if you take the round ligament, okay, here, okay, so this is where the round ligament starts. Okay, so let us take this as a round ligament. If you take round ligament, the interstitial pregnancy will be lateral to the round ligament, whereas angular pregnancy will be medial to the round ligament. Clear? So, relationship to the round ligament. Okay. Okay. So, interstitial pregnancy is lateral to the round ligament and this is medial to the round ligament. Okay. And we already know that this is a extra endometrial ectopic pregnancy. Okay, whereas an angular pregnancy is a intra-endometrial pregnancy, but it is not an ectopic. Clear? And another point is, most of the times, interstitial pregnancy can be non-viable also. Okay, but if you see in a angular pregnancy, viable pregnancy is possible. Clear? And remember, both of them have a chance of increased rupture. Okay? And if you see the ultrasound findings in interstitial pregnancy, we have already seen, you will be able to appreciate interstitial line sign. Okay? And a G-sac is seen separately from the uterine cavity. And remember the fact that in an interstitial pregnancy, there will be thinning up of the myometrium. Okay, so the myometrium will become very thin and it will be less than 5 millimeter. Okay, so thinning up of the myometrium. Whereas in an angular pregnancy, the gestational sac will be surrounded by an endometrium and there will be a thick myometrial layer. Okay, so G-sac surrounded by endometrium and there is a thick layer of myometrium also. Clear? So, I hope you would have understood now what is interstitial pregnancy and what is angular pregnancy, right? See, Cornwall pregnancy is a rare form of ectopic pregnancy. And in this, the pregnancy will be happening in the rudimentary horn of the uterus. Okay, so that is uterus with the Mullerian anomalies, and that rudimentary horn can be communicating with the uterine cavity or it may not be communicating with the uterine cavity. Okay, so it happens in the rudimentary horn of the uterus. Clear? And remember, cornal pregnancy is a kind of ectopic pregnancy. Clear? Now we will see the images for better understanding. Right? Okay. So this is the interstitial pregnancy. Okay. And this is the angular pregnancy. Okay. See, it is in the supralateral aspect of the endometrial cavity. Okay. And if you take the round ligament, it is medial to the round ligament. Okay. Whereas an interstitial pregnancy is lateral to the round ligament. Okay. And this is a cornal pregnancy. You are able to see two horns of the uterus here, and most of the times it will be happening in the rudimentary horn of the uterus. Okay. And these two types, okay, that is interstitial and cornal, or a type of ectopic pregnancy, whereas angular pregnancy is not considered to be a ectopic pregnancy. Clear? Okay. Now, ovarian pregnancy is the second most common type of ectopic pregnancy, but even then it is very rare. Okay. So, it is rare and it can happen in 1 in 7,000 pregnancies. Okay. And one important thing is the diagnostic criteria for ovarian pregnancy is given by the Spiegel-Berg's criteria. Okay. So, it is Spiegel-Berg criteria. Okay. We will see one by one what are the criteria. Like first one, see, whenever there is an ectopic pregnancy in the ovary, the ipsilateral tube should be normal and it should be distinct from the ovary, right? So, that is the first point. So, ipsilateral tube is intact and is distinct from the ovary. And for sure, you should be able to see a gestational sac in the ovary itself. Okay. So, there should be a G-sac in the ovary. Okay. And this ectopic pregnancy in the ovary, it should be connected to the uterus by the utero-ovarian ligament. Right. So, ectopic pregnancy is connected to the uterus by the utero-ovarian ligament. Okay. And when you take a histopathological examination after surgery, you should be able to see the ovarian tissue in the gestational sac of the ectopic pregnancy. Clear? So, ovarian tissue seen in the wall of G-sac. Clear? So, these are the 4 criteria. We will repeat once again. So, first one, ipsilateral tube is intact and it should be distinct from the ectopic, or that is the ovary, and G-sac should be present in the ovary, and the ectopic pregnancy should be connected to the ovary by the utero-ovarian ligament, and when you do a histopathological examination, you will be able to see the ovarian tissue in the G-sac of the ectopic pregnancy. Clear? Okay. So, if you see the ultrasound picture, you will be able to see a G-sac, okay, that is surrounded by a echogenic area widely, okay, and it will be surrounded by the ovarian cortex. Clear? Okay. So, this is the ectopic pregnancy in the ovary. So, you are able to see the uterus separately. Okay. So, this is the left ovary. Okay. That is separately seen, and in that you are able to see a ectopic pregnancy. Okay. So, this is a pic again. You are able to see this is the uterus. Right. Okay. So, the uterus is going like this, and this is the ovarian tissue. You are able to make it, right. So, this is the ovarian tissue, and in that you are able to see a G-sac. Clear? Okay. So, the criteria is known as Spiegelberg criteria, very important, right. Next, we will see cervical pregnancy. See, cervical pregnancy is also one of the rarest pregnancies, that it will occur only in less than 1% of the people. That means it is very rare and it can occur in 1 in 9,000 pregnancies, right. So, what is happening here? The blastocyst implants in the endocervical canal. Endocervical canal. Okay. And in 90% of the women with the cervical ectopic pregnancy, they can have painless vaginal bleeding. Okay. Sometimes you have to differentiate this with miscarriage. Okay. And you have criteria for cervical pregnancy also, that is, the older criteria was Rubin's criteria and the recent one is Hallman criteria. Okay, we will see what are the features of Hallman criteria. If we take the cervical os, we have two os, right? You will have an internal os and you will have an external os. Okay, the internal os will be closed and the external os will be partially open. Okay, and the G-sac will be seen attached itself to the endocervix. G-sac attached to the endocervix, and as we have already seen, bleeding can be present. Clear? Now we will see what are the USG features of cervical ectopic pregnancy. See, when ectopic pregnancy is present in the cervix as well as the uterus are going to dilate. Okay, see, if it is like this, this is the uterus, okay, this is a cervix, okay. A pregnancy is happening here, okay, in the endocervical canal, and what is going to happen is, this is going to dilate the cervix and sometimes dilatation of the uterus is also going to take place, okay. So, finally, if you see, since both are dilating, you will be able to see a hourglass shape, okay, and definitely there will be a empty uterine cavity. And where will be the G-sac? Yes, at the level of cervix. And on colored Doppler, what you will be able to see? Yes, it is increased vascularity at the cervix. And there is a sign called as negative sliding sign. Okay. So, what does this negative sliding sign means? When you are using the vaginal probe to move the cervical ectopic, it will not move any further. Okay. So, with the probe it is not moving. So, it is known as negative sliding. It is not sliding by the probe movement. Okay. So, vaginal probe fails to move the implanted gestation. Clear? Okay, so you will have an empty uterine cavity, G-sac at the level of the cervix, and then you will have a hourglass shape because both the uterus and cervix is going to get dilated. There will be increased vascularity that we have seen, and negative sliding sign will be seen in the case of cervix. Okay, so this is an ultrasound picture of a cervical ectopic. Okay, I hope you are able to see how this hourglass shape is coming, right? Okay, so this is the uterus level, and this is the cervix level. There is a cervical ectopic pregnancy, and remember there is a closed cervical os and the closed cervical internal os, okay, whereas the external os can be partially open also, because this developing pregnancy will be going to give a pressure on the external os, okay. And remember, this is also another important criteria, you will be having an empty uterine cavity, right. Next we will see about the abdominal ectopic. See, there can be two types of abdominal ectopic, okay. A primary abdominal ectopic is an ectopic pregnancy which has implanted itself in the peritoneal cavity itself, okay. So, implantation in the peritoneal cavity, whereas a secondary ectopic, okay, it may follow tubal rupture or tubal abortion as we have seen previously, okay. So, occurs after tubal abortion or tubal rupture, and in both these types it is the second type which is most common, okay. So, secondary abdominal pregnancy is most common, okay. And there is a criteria for abdominal pregnancy also, we call it as study 4 criteria, okay, it is study 4 criteria, okay. As usual, can you tell me? Yes, tubes and ovaries should be normal. Second one, pregnancy should be exclusively linked to the peritoneum, okay. And there should not be any uteroplacental fistula, and there should not be any uteroperitoneal fistula. Okay, so almost in the ultrasound findings also, it is very easy, right? So, we should be able to see the fetus or the placenta in the abdominal cavity. Okay, that is separate from the uterus. And there should be lack of myometrium between the fetus and the mother's anterior abdominal wall or the bladder, okay. So, lack of myometrium between the fetus and the maternal anterior abdominal wall or bladder, okay. And since it is present in the abdominal cavity, there will be bowel loops that will be surrounding the gestational sac or the embryo, okay. So, bowel loops surrounding the sac. See, this is one of the ectopic pregnancy where the pregnancy can continue even up to term, okay. So, that should be kept in mind, okay. If it is an abdominal pregnancy, a pregnancy can go even up to term in the abdominal cavity, okay. So, this is a picture, I hope you are able to appreciate, okay. You have, see, this is the uterus, okay, this is the uterus, okay. You have the uterus bladder here and the baby is comfortably lying in the abdominal cavity and it is a term baby. Can you able to appreciate, okay. See, similarly here also in the ultrasonogram, see a pregnancy, okay, that is separate from the uterus, okay. So, this is where the uterus is, okay, but the baby is lying comfortably here, you are able to see the head, everything, okay. The baby is completely developed here also, it is completely seen in the abdominal cavity, okay. And in some cases, if needed, apart from ultrasound, MRI can also be done in these cases. Clear? Next we will see about cesarean scar pregnancy. Okay. So here what is happening is the implantation is happening in the myometrium of the previous cesarean section scar. Okay. So implantation within the myometrium of a previous cesarean scar. Okay. See, it is one of the rarest pregnancies. Even then, because of the increased cesarean section rates now, the incidence of cesarean scar ectopic is also getting increased. Okay. So, incidence increased nowadays due to increased rates of cesarean section. Okay. If you take these cases, if you see 60% of the cases, they will be presenting symptomatically with bleeding and pain. Okay. And in 40% of the cases, they are asymptomatic, okay, and they are diagnosed only by a ultrasonogram. Clear? If you take cesarean scar pregnancy, it can be further divided into an endogenic cesarean scar pregnancy and an exogenic cesarean scar pregnancy. Okay. So, cesarean scar pregnancy can be classified further into endogenic type and exogenic type. Okay. If you take the endogenic type of cesarean scar pregnancy, endogenic means it will be going towards the uterine cavity. Okay. When it is going towards the uterine cavity, the outcomes can vary. Okay. So, in exogenic cesarean scar pregnancy, what will be happening is the pregnancy will be growing towards the abdominal cavity or the bladder. Okay. So, what will be happening is this may complicate itself as placenta accreta spectrum also, right? And sometimes this may even necessitate the hysterectomy. Clear? So, in endogenic, the pregnancy growth is towards the uterine cavity. Okay. Whereas in exogenic, the growth is towards the bladder or abdominal cavity. Okay. And in endogenic type, there can be variable obstetric outcomes. Okay. Whereas in exogenic type, it may complicate itself as placenta accreta spectrum, and that may increase the need for hysterectomy. Okay. Now, if we see the ultrasound findings in a cesarean scar pregnancy, okay, we should mark the uterine length as such, okay, and you will be marking a midpoint also. Suppose if it is distal to this midpoint of the uterine length, then it is a cesarean scar pregnancy, possibly if she already has a history. And suppose if it is proximal to this line, then it can be considered as a intrauterine pregnancy that has happened at the cervico-isthmic junction. Okay. And if you put color Doppler, definitely there will be increased vascularity. And here also we will be having negative sliding sign. So, the probe fails to move the implanted gestational sac. Okay. Clear? Okay. Now, we will see the peak. So, you have the uterus, okay, with the cesarean scar. Okay. So, this is where the incision was given in the previous cesarean section, and this is where a pregnancy got implanted exactly. Okay. So, in this ultrasound picture, you are able to see the uterine cavity and the cervix. Okay. So, this is the uterine cavity and this is the cervix, and here a cesarean scar pregnancy is also seen. Clear? I hope we are done with all the types of ectopic pregnancy the criteria and the ultrasound diagnosis. Okay. As we have made the diagnosis, now we are going to deal with the management part. Okay. So, management of ectopic pregnancy. First, we will see for a tubal ectopic. Okay, since this is the most common one. See, you can have two modes of management, either a medical management or a surgical management. We will see the criteria for that also. Okay. So, medical management and surgical management. See, for medical management, the patient should be stable first, right? So, the vitals are stable in the patient. Okay. And it should be a unruptured ectopic. Okay. And if you go for investigations, the beta HCG value should be less than 5000 international units. Okay. And in the ultrasound, the sac size should be less than 4 centimeter. Okay. And definitely the cardiac activity should be absent. Okay. Cardiac activity absent. Simple. Okay. We will apply the rules for surgical management now. Yes. So, here when the vitals are unstable, definitely we are going for the surgical management. Yes. When it is a ruptured ectopic, then we are going for a surgical management. Yes. When the beta HCG value is more than 5000 international units and when the sac size in the ultrasound is more than 4 centimeter and also when the cardiac activity is present. Okay, we are going for a surgical management. Clear? And remember, two more important factors for doing medical management. One thing, the patient should be motivated. Okay, for treatment. And she should be compliant enough for follow-up. Okay, so compliance for follow-up should also be there. Clear? Now, the most important drug that we use for medical management is, yes, it is methotrexate. Okay. So, medical management is done with methotrexate. First, we will see what is methotrexate, then we will go on for the regimens, right? See, methotrexate is a folic acid antagonist. Okay. So, it will be binding to dihydrofolate reductase and it will be blocking the conversion of dihydrofolate to tetrahydrofolate. Okay. So, dihydrofolate is converted into tetrahydrofolate by dihydrofolate reductase. Okay. Now, methotrexate binds to this, okay, and this conversion is not happening. So, tetrahydrofolate is not formed. Okay. So, methotrexate is active against most of the rapidly proliferating cells. Okay. So, that includes not only trophoblast but also the gastrointestinal mucosa, the bone marrow, the respiratory epithelium, etc. Okay. So, acts on rapidly proliferating cells including trophoblast, gastrointestinal mucosa, bone marrow and also the respiratory epithelium. Okay. It is a potent teratogen also and it is cleared by kidneys. Okay. So, before starting methotrexate, you should obtain CBC, LFT and RFT test. Okay. So, CBC, LFT, RFT to be done before starting it. Okay. So, while you are giving methotrexate, you have to withhold certain things. Okay. So, you have to withhold, number one is folic acid supplements because there is binding to dihydrofolate reductase. Next one, you have to stop NSAIDs also, okay, because they decrease the renal clearance of the drug, okay, and hence it may increase the renal damage, okay. Alcohol should also not be taken because it can worsen the liver function. And exposure to sunlight while taking methotrexate can sometimes cause dermatitis. And coitus while taking methotrexate for ectopic pregnancy should be avoided because there can be an increased chance of rupture. The dose of beta-HCG is calculated as 1 milligram per kilogram. Okay, so for an average Indian woman, it is 50 milligram per meter square of body surface area. Okay, and this is usually given as a intramuscular injection. Okay. Now, consider I have given methotrexate on day 1. Okay. Now, what I will do is, I will repeat the beta-HCG levels on day 4. Okay. Sometimes there can be a slight increase in serum beta-HCG levels on day 4. Okay. So, what we will be doing is, we will be checking next beta-HCG level on day 7 also. Okay. Now, I will see the difference between this day 4 and day 7. Okay. Suppose there is more than 15% decrease in the levels or there. What we will be doing is, we will be repeating the serum beta-HCG levels every weekly. Okay. Until it becomes to less than 5 milli international units per ml. Okay. We will be doing it every weekly. Okay. Suppose there is less than 15% of the fall in the beta-HCG levels means, I will be giving another dose of injection here on day 7 and I will be repeating the serum beta-HCG values on day 11. Clear? Okay. So, once again I will see, we are giving on day 1 the injection, on day 4 a slight increase can be there. Anyhow, you are going to note down the value and you have to repeat the serum beta-HCG value on day 7 also. So, you have to compare the levels between day 7 and day 4 now. Okay. So, if there is a more than 15% fall means, then your methotrexate injection is working out. Okay. So, what you will be doing is, you will be doing a serum beta-HCG level every weekly until the HCG values become very less, that is, it becomes less than 5 milli international units per milliliter. Suppose if it is not reducing and there is only less than 15% of the reduction in the beta-HCG values means, you have to repeat the second dose of methotrexate, okay, the same dose 50 milligram per meter square on day 4 also, and you will be doing the beta-HCG levels on day 11. Clear? Yes. Now, we will also have a multidose regimen. Now, in multidose regimen, we will be giving methotrexate at a dose of 1 milligram per kilogram. On the days when we are not giving methotrexate, we will be giving folinic acid at a dose of 0.1 milligram per kilogram body weight. Clear? See, for example, on day 1, 2, 3, 4, 5, 6, 7, 8. Okay. I choose to give injection methotrexate on day 1. So, I will choose 1, 3, 5, 7 days for methotrexate. Okay. And on the alternate days, that is 2, 4, 6, 8, I will be giving folinic acid at a dose of 0.1 milligram per kilogram. Okay. So, whenever I am giving injection methotrexate, that day I will measure serum beta HCG levels. Okay. And the reduction between the two levels should be more than 15% from previous value. Okay. From previous value, there should be more than 15% of reduction. Okay. And it should be followed up till HCG falls less than 5 milli international units per milliliter. Clear? Okay. So, this is all about your medical management. Next, we will see the surgical management. Surgical management in a case of tubal ectopic can be done by two routes, either by a laparoscopy or by a laparotomy. Okay, this is mostly preferred when the patient is unstable. Okay, and if the patient is stable, okay, you can take her for laparoscopy. Okay, now already we have seen the indications for surgical management. Now I will go to the options available. You can go for one is salpingostomy, okay, and another one is salpingectomy. Now, how to remember this? This O you have to see. O has a hole, right? So, what we are going to do is, you are going to put a hole in the tube, okay. Whereas, gectomy, okay, means you are going to remove the tube completely, okay. So, we will see salpingostomy. So, we are going to remove the ectopic gestation through an incision made on the tube. Okay, but you have some drawbacks of salpingectomy. While doing so, some of the cases can get converted into salpingectomy. And if you are just leaving the tube as it is, we have already seen that there is a increased risk of ectopic pregnancy when there was a prior ectopic pregnancy as well as when there was a tubal surgery, right? So, the risk of ectopic pregnancy is increasing in this case if you do a salpingostomy. Okay. So, the preferred method is salpingectomy. Okay, where we will be removing the tube, and a total salpingectomy, that is complete removal of the tube, is preferred always. Okay, because number one, sometimes the tubal damage already would have been extensive. Okay, the tubal damage is already extensive, and there was a bleeding happening which is uncontrolled bleeding. Okay, and the ectopic pregnancy is too large. That means it is better to completely cut off the tubes. Okay, and you will be reducing the risk of ectopic pregnancy in the future pregnancies. Okay, risk of ectopic in future pregnancies in the same tube. Okay, but remember, there can be again a chance of ectopic if the other side tube is left open. Okay. So, this is a picture of salpingostomy, it's a hole, right? So, we will be just putting a hole here. Okay, most of the times you can do it by hydrodissection, and you can leave it unsutured also. Okay, and this is salpingectomy, where you will be cutting off the tubes completely. Clear? And next ectopic we have discussed is ovarian ectopic. So, ovarian ectopic management. Most of the times, ovarian ectopic needs only surgical management. Okay, suppose if it is a smaller gestational ages, then you can go for a ovarian wedge resection, and suppose if the gestational sac is too large, then you have to go for a oophorectomy as it is. Okay, so most of the times it is surgical management. So small lesions, I'll do a ovarian wedge resection. Okay, and for larger lesions, we'll do a oophorectomy. Okay, next is cervical ectopic. In case of cervical ectopic, you can prefer to go for a medical management or a surgical management. And in the medical management, you can prefer to take single dose regimen or a multi-dose regimen, as we have discussed previously. And since it is a cervical ectopic, sometimes suction and evacuation are tried. In rare cases, hysterectomy can also be needed. Okay. Next is abdominal ectopic management. Already we have seen abdominal ectopic pregnancy is a pregnancy which can be carried up even up to term. So, what you will do is you will go for a laparotomy and pregnancy termination if you find a abdominal ectopic at term, and in this case the placenta removal will be difficult. Okay, you have to carefully clamp the blood vessels that is supplying the placenta, and you have to try to remove the placenta. But in some cases, when it is adherent to the bowels or something, okay, in that cases it cannot be removed. Okay, so what they advocated, sometimes the placenta can be left inside to itself. Okay, and you have to monitor for absorption of the placenta by doing serum beta HCG levels, color Doppler, and even MRI. But remember, this placental absorption may take months or years. Okay, sometimes if it is left alone, a course of methotrexate postoperatively can also be given. Okay, and suppose if you had find it earlier in gestation itself, then you can give a local injection of vasopressin inside the gestational sac. Okay, if you find it in early gestation. Clear? Okay. Now suppose it was a heterotopic pregnancy. What you will be doing is, you will be doing steps that will include to disrupt the ectopic pregnancy alone. Okay, suppose you can give a potassium chloride injection into the sac, or hyperosmolar glucose into the sac. Definitely, what we are doing, methotrexate is not given. Methotrexate not given in heterotopic pregnancy. Clear? Yes. So, with this we are completing the ectopic pregnancy topic. This is a vast discussion involving 2 sessions, but even then we have done almost every point of ectopic pregnancy. So, until we meet in the next video, take care, happy learning, and bye-bye.